to the next presentation, where basically, so I sort of went back and forth. I started by describing the project. Dr. Fuster through the challenge, what is really the challenge once you know the risk. Now, I think we're coming back to define actually the challenges of knowing the risk. So it's a double challenge tonight. And our speaker here is Dr. Armin Zadeh from Johns Hopkins. And he is online to share with us challenges and opportunities in predicting acute coronary events. Dr. Zadeh, are you on the line?
Yes, I am. Good evening from Baltimore. Can you hear me?
Yes, we can hear you well. Please, go ahead.
Thank you for the opportunity to be part of this exciting event. We'll talk about our specific contribution to this project a little later, but as kind of an introduction, I will spend the next few minutes to discuss some of the challenges, but also opportunities in predicting acute coronary events. So this is the kind of scenario.
Dr. Zadeh?
Can you expand your slides to slideshow? We're only seeing a small thumbnail.
Well,
I think if you go to display settings, you should have the option. Go to slideshow.
Actually, down there, press on that, or a slideshow, or F5.
Actually, if you go to the slideshow tab at the top, next to animations and review. Yes.
Well, it is at a slideshow right now.
Well, maybe
the issue is that the screen is not, it's not the right. I have to change the screen.
All the way top, it says 42%. Can you make it like 100%?
No,
well, no, the issue is that I have to change the screen. I'm operating two screens, so is there a way to, let me see. Yes, this is probably it. All right.
Okay, perfect.
How's that?
Okay, good.
Okay. Sorry about that. Give me just 1 second here. All right, so this is the kind of scenario we are trying to prevent here. Shown is a histology slide of the proximal AD of an unfortunate 37-year-old man who died suddenly. We can appreciate that the vessel lumen is filled here with thrombus overlaying a large plaque with a necrotic core. The thrombus actually was triggered by a plaque erosion, not rupture, as the fibrous cap is still intact, as you can see here. And from imaging and pathology studies, we know that plaque erosions and plaque ruptures account for most of the culprit lesions in patients suffering acute coronary events. And this knowledge led to the assumption that detecting plaques prone to plaque disruption would allow identifying individuals at high risk of suffering acute coronary events. This assumption, however, is challenged by the fact that plaque ruptures frequently occur without causing any clinical syndromes. In this table, we went through the exercise summarizing the prevalence of plaque ruptures not associated with acute coronary syndromes in different populations, including normal controls, patients with stable coronary heart disease, and those with acute coronary syndromes triggered by other culprit lesions. Plaque ruptures are typically difficult to detect, particularly by imaging techniques, but even pathology studies do not identify all plaque ruptures, and as such, these numbers most certainly underestimate the true prevalences of ruptured plaques. Now, the first two rows here, they show data from pathology series, which probably are closest to the true prevalence, revealing that 17 to 31% of normal controls, but our patients who died of non-cardiac causes had ruptured plaques in their coronary tree, which were not associated with coronary thrombosis or symptoms prior to their death. And below are data derived by IVUS in patients with stable coronary heart disease, and you can see that these numbers are somewhat lower, as IVUS is not the ideal tool to detect plaque ruptures. Using OCT, on the other hand, which is more sensitive, we see prevalences closer to those by pathology, particularly considering that these techniques are far from perfect detecting plaque ruptures. The results indicate that plaque ruptures are present in a substantial number of patients without evidence of acute coronary events. In patients who do have ACS, and these are the last two columns here, triggered by other lesions, we find that non-corporate plaque ruptures are even more frequently present as an expression of a pan-vascular as opposed to a local process. You see here about 50% show non-corporate plaque ruptures in the patients with acute coronary syndrome. And we also know from pathology studies that the vast majority of stenotic plaques reveal evidence of prior ruptures, as shown in this example, where the collagen tissue, stained here in green, is filling the gap of a large rupture in this advanced plaque. And once the tissue has filled the gap, it is exceedingly difficult to recognize that a prior rupture occurred, hence the underestimation of prior ruptures, even by histopathology. Pathologists therefore believe that most, if not all, advanced plaques have underwent prior ruptures. And if we are lucky, we catch the sequence of events in one frame, such as demonstrated here. This plaque contains evidence of the three prior ruptures, actually, here, there, and there, which is associated with the healing process and the expansion of volume. These data from several pathology groups actually demonstrating that repeated plaque ruptures are an important mechanism for plaque growth, explaining the often rapid development of stenosis over a short period of time. So given the evidence of prior plaque ruptures in most lesions with a stenosis of 50% or greater, and given the evidence that at least 5 to 10% of the asymptomatic population have coronary stenosis of such degree, even among relatively young individuals dying of non-cardiac causes, as shown here in the autopsy series from Mayo Clinic, we must conclude that plaque ruptures indeed occur quite frequently and in most cases do not lead to clinical syndromes. The great British pathologist Michael J. Davis knew this all along. He's quoted to have said this in the 1990s already, that the vast majority of plaque ruptures occur without clinical symptoms. And therefore, detecting plaques prone to rupture does not necessarily identify patients at high risk, because most of these will rupture silently. It's therefore also not surprising that many of the efforts to identify high-risk patients by the means of vulnerable plaque imaging have been disappointing. The million-dollar question really is, and Michael Davis was among the first posing this question, what does go wrong in these exceptional cases in which a plaque rupture does cause an acute coronary event? And the short answer is we don't know what ultimately has to go wrong for allowing vascular thrombosis to occur in response to plaque erosion or rupture. For the regular scenario, that is an asymptomatic plaque rupture, we assume that the thrombosis containing factors are aligned to prevent more than a local intramural thrombus. So in this more common scenario, the plaque ruptures, but the artery remains patent and the plaque heals and grows. In the more unlikely scenario of an acute coronary syndrome, thrombosis promoting factors at the time of rupture seem to tilt the scale in their favor and allowing partial or complete vascular thrombosis to occur. And again, we don't know which factors are particularly relevant in this scenario, but it appears that these are highly complex events involving numerous factors. Ultimately, the risk of an acute coronary event is the result of the interplay between the stimulus for thrombus in the coronary tree and the vulnerability of the system for clinically relevant vascular thrombosis. Some, but surely not all, factors are outlined here in the schematic, including many of our typical risk factors for coronary events, and many of them related to inflammation. And as Chairman Dr. Nagavi and the SHAPE committee astutely summarized in their 2003 position paper, it is about the vulnerable patient and not just about plaques. And we as cardiologists are particularly guilty neglecting the clinical importance of the vulnerable blood in the process. Indeed, it is the response to the plaque alteration which determines the outcome. And unfortunately, this response may vary substantially depending on the particular conditions at the time of plaque rupture. So the challenge to predict the response of the blood to the stimulus of thrombosis in the coronary tree at the time of rupture or erosion is illustrated here by evidence of the large performance variability of the coagulation system, which really is in constant flux, varying almost minute to minute, and shown are the activities of several hemostatic factors over several hours on the left and over the year on the right, demonstrating substantial diurnal and seasonal variability for fibrinogen, D-dimer, TPA, von Willebrand's factors. This is just an example of some of these. And so not accidentally, acute MIs occur more frequently at certain times during the day, particularly in the morning hours, where catecholamine levels tend to be higher with a more thrombosis favoring milieu. And the autonomic nervous system likewise underlies a strong circadian rhythm, and the complex interplay of vascular tone, blood flow, hemostatic factors likely determine the final outcome. So given the numbers of factors involved, the complexity of mechanisms, and their temporal variability, we are likely looking at a perfect storm scenario for acute coronary events to occur, which explains our difficulty in acutely and accurately predicting these events. The good news is that we do know some of the key factors affecting risk. Foremost, we must have atherosclerotic disease to be at risk. If we don't have coronary atherosclerotic disease, our risk of sustaining an acute coronary event is exceedingly low. Conversely, the greater the disease burden, the greater the risk. And remarkably, there's really a near linear relationship between the coronary calcium score as a crude marker or estimate of the atherosclerotic disease burden and mortality. And this relationship is intuitive. The more atherosclerotic disease, the greater the number of plaque erosions and ruptures occur in the coronary tree, and thus the greater the probability that plaque alteration happens at a vulnerable time of the coagulation system. However, this concept works reasonably well on a population basis, but it still does not allow high accuracy of predicting short-term events in an individual. And in order to increase our ability to identify patients at risk, we need indeed to integrate a large number of individual factors which may indicate an unfavorable response to the stimulus of thrombosis. And it's here that machine learning may indeed help identifying which factors in which combination infers the greatest risk. Disposition clearly plays a major role in this context, and there's great interest in the disentangling genetic patterns associated with increased or decreased probability of allowing vascular thrombosis in response to plaque disruption. So I'd like to close with a proposal from our side for the use of clinical data in support of the machine learning project. We coordinated 2 international multi-center studies on the accuracy of CT coronary angiography for the diagnosis of coronary artery disease compared to cardiac catheterization. And we are collecting long-term follow-up in these participants for comparing patient outcome according to imaging findings. These studies are the Core 64 and Core 320 studies, and the specific value of these data sets lies in the fact that these were fairly high-risk patients as opposed to some of the primary prevention population, such as MESA, etc. I mean, these are symptomatic patients, higher risk patients with event rates, heart event rates of about 2% per year. So despite the rather small patient populations, we expect to see a good number of events because of the length of follow-up and the risk characteristics of the populations. And we are particularly excited to be able to compare risk assessment using different tools such as coronary calcium scanning, stenosis assessment, stenosis location, plaque characterization, perfusion assessment. So we have a real array of possibilities here to compare, which should help identifying the most appropriate ways to risk stratify patients as we ultimately need to practically apply our methods in patients. So in conclusions, the mechanisms leading to acute coronary symptoms are highly complex and underlie substantial temporal variability, which really hinders accurate prediction. At the same time, integration of coronary artery disease characteristics and risk factors for vascular thrombosis into comprehensive models may identify individuals at increased risk. And clinical studies are needed to isolate metrics of greatest predictive value in comparative analysis. And with this, I'd like to close and again express my gratitude to the organizers for allowing me to be part of this exciting project.
Thank you very much. Dr. Zadeh. So we're going to show, please go ahead. Dr. Narula has questions.
Sorry, I told you when Dr. Booster is here, I don't open my mouth. So, Armin, excellent presentation, and Dan and I are sitting here and admiring the way you presented it. And so there is no question about the vulnerable patient. Nobody will question that. That vulnerable patient is the most important thing to follow. It is all about risk factors. And once you know about the risk factors, we really know about the disease. But when we talk about the vulnerable plaque, there is a fundamental problem that we are suffering from. And there are two papers which we just put out, one in JAMA Cardiology, June 16th issue, and second one was in the July issue of Circulation Research this year, where we said that the problem is not having a vulnerable plaque, problem is freedom from the vulnerable plaque, which is more important. So negative predictive value of a plaque which is not vulnerable is very high. And the positive predictive value of any way you image a plaque, your positive predictive value is very low, and that was in the editorial which Sanjay Kaul and I put into Jack last year. And so what we tried to show there was that when you talk about the negative predictive value of a stable plaque, it ranges between 94% to 99.8%. And if you look at a positive predictive value, the best you do is with CT, where you have 45 times higher likelihood of having an event in the next 2 years' time, or 10 times higher likelihood of having an event over the next 10 years. Now, if you look at the FAME data, very clearly tells you that if I have angiographically done decision versus FFR done decision, FFR performed 40% better than the angiographically done decision. Now, when I do it, this is by patient. When I look at by lesion, there is no difference in angiographic MI, which was 3.9% versus FFR decided lesion, which was 3.7%. So significance being not significant. However, when the FFR negative lesion was seen, there was only 0.2% likelihood of having an event. 2 out of 1,000 people would have an event if FFR was negative. On the other hand, if FFR was positive, you will have to do 100 angioplasties to save 8 events. Okay, now you go from there to Prospect. Prospect has 697 subjects, 3.4 years follow-up. And if you look at 0 vulnerable feature, 1, 2, and 3 vulnerable feature. 0 vulnerable feature, 0.3% likelihood. 1 vulnerable feature, 5% likelihood. 2 features, 10% likelihood. 3 features, 20% likelihood in 3.4 years. Now, how many people out of 3,000 lesions had three features? 29. So 1% of the people have that. Of that, 1/6 have an event. What is the positive predictive value in the tank? Right? On the other hand, negative predictive value 0.3% over the next 3.4 years. So it is the negative predictive value which is important. Why? Because the positive predictive value has lots of problems. Number one, our CT study with a 10-year follow-up clearly showed that if I have 2 scans, 2 things which really make a difference. Not only the high risk plaque, but if it is stenotic, 7 times higher likelihood. So stenosis plus high risk plaque. And if in 2 CTs are done at an interval of 1 year, which was 500 cases out of 3,000, and if plaque shows progression over the next 1 year, 37 times higher likelihood of having an event as compared to the plaque which is not showing any event. So it is the dynamicity of the disease which is important. Is the plaque enlarging? And is it enlarging because of the lipid core rather than anything else? So there is a significant positive predictive value issues here. And that too, Dan and we have doing this stuff together now, where we are trying to demonstrate that FFR also is not determined alone by the QCA. It is not determined at all by the lesion length. It is determined by the QCA and the amount of lipid core sitting outside the plaque. Lipid core sitting outside the plaque has a higher multivariable contribution to the FFR, and that is the reason that FFR picks up the disease better than the angiography. And I tell you, I normally show a very small clip where an Italian farmer is relaxing in a farm, and there is a donkey which is sitting next to him, and there is a person who comes on a Vespa, and he says, "Sir, do you have time?" And he picks up donkey's ball and says, "Yes, 15 past 10." So he says, "Sir, are you sure?" He picks up balls again, and he says, 15 past 10. So he fixes his watch and goes. In the evening, he returns back, and he wants to test him because he's still intrigued. He says, "Sir, do you have time?" He says, "Again?" He says, "Yes." So he picks up donkey's ball again, and he says, 10 past 7. Damn, it is 10 past 7. "Sir, how do you figure out the time by picking up donkey's balls?" So he picks up donkey's ball, shows there's a village club behind there. So what I tell people is that FFR is donkey's ball, and the village clock is the pathology. Until unless you have a pathology, you don't have an abnormal physiology, right? So if you really have to pick up something, the only way to do that is looking at pathology also in addition to it. But you have to demonstrate that the lesion is dynamic. Unless the lesion is dynamic, you are not going to pick it up. So the best way of identifying a subject is this guy is not going to die. That's all. Not that this guy is going to die.
Well, this is really fascinating because you just tied this to the power of zero discussions that we had in coronary calcium. And after so many years of discussion of using calcium to identify risk, now using zero to eliminate those people who don't. So you're basically creating the power of zero version of angiography. But the challenge that Dr. Zadeh is trying to bring our attention is that, there are a lot of people who are not going to have an event. Finding people who are not going to have an event, how is it going to help us with finding people who are going to have an event? So your short answer is we don't have the resolution or the predictive power to do anything in that area. Is that your fundamental? Yeah. Any comment here? I'm going to go back to Dr. Zadeh, see if he has anything. Anybody else? Any comment?
I'm sorry, I didn't, unfortunately, I wasn't able to hear all of Jagat's comments. I heard just something about Prospect and FFR, and I have strong feelings about these studies. in general, let me just say, in general, one of these issues is with all these many studies out there. That they're using very, very different endpoints, and that often leads to confusion. In many of the FFR studies, looking at revascularization, hospitalization, and really don't compare heart events in where they're really, as far as I know, really don't have any stronger predictability compared to atherosclerotic disease burden. I mean, the Prospect study similarly is very, I believe, widely misunderstood because it shows indeed that there's a higher, if you have a higher individual lesion plaque burden, that you have a greater risk of events. But these events, again, they were almost all of them were hospitalization for angina without evidence of an acute coronary syndrome, without evidence of myocardial infarction. And in fact, obviously, if you have a baseline, if you have a more advanced plaque, you will be likely for that plaque to advance and follow up and to cause symptoms. So what really all Prospect showed was that if you have a greater disease burden at baseline, it will, be more likely symptomatic at follow-up. But it did not show that you can identify individual plaques which are associated with much greater likelihood of acute coronary syndromes, and that's really the challenge. And the challenge is really that the concept of acute coronary syndromes is so complex that the single plaque imaging clearly is not enough. But in an FFR, obviously looks at a whole different issue altogether, more blood flow restriction. And there often the problem is if you have a higher FFR values, then you're also looking at greater disease burden and stenosis severity. So these things are very difficult to disentangle, but overall, I very much agree with Dr. Narula that that is very important to look at the negative predictive value.